greetings to the chairpersons and the available participants on the floor. I'd like to introduce myself. I'm Dr. Sagun Manandhar, serving as an assistant professor at Patan Academy of Health Sciences currently. And this few presentation slides will be more as an experience sharing rather than like a conventional topic presentation or a lecture. So I'll be including the overview of my fellowship program, following them with some interesting representative cases, and then concluding with the reflection and remarks on future prospects. I have no disclosures to make. Along with Professor Dr. Ram Kumar Gimre, I'd like to acknowledge all senior interventional radiologists whom I got a chance to train under during my fellowship as well as my residency program. The fellowship I was enrolled was an NMC accredited program. So it was acknowledged by the Medical Council of Nepal. It was organized in collaboration with NSVIR for a duration of 1 year. And my primary site of training was Nepal Medicity Hospital, and also got to train at IOM TUTH as well as Sir Gangaram Hospital, New Delhi. So in addition to the hands-on procedures that I got to do, the other training modalities were the topic presentations, the case presentations, various interdepartmental meets, and maintaining the logbook of procedures. And for the certification, I was required to complete a research in interventional radiology, and there was an exit exam conducted by the NSVIR. So presenting some of the interesting cases. So starting with those in the ablation. So here, this is a video presentation showing the thyroid nodule, which was proven to be benign by FNAC. And here we can see this the positioning of the needle and the formation of the ablation cloud after we did the hydrodissection of the carotid vessels. And we can see the post-ablation changes in this thyroid nodule. And we followed this patient progressively in a month interval for a few months, and there was considerable decrease in size of the nodule. The other one is the typical case of osteoid osteoma in a 15-year-old female. Here we can see the lesion, the osteoid osteoma, and we did the microwave ablation here with the help of a bone biopsy coaxial, and through it we placed the antenna of the microwave ablation. And there was immediate relief of pain and improvement in the quality of life starting from the second day of the procedure. Another is a typical case of HCC in the background of a cirrhotic liver in an elderly male patient. Here we can see this is the placement of a microwave antenna again. So we do this procedure under USC as well as CT guidance with the help of sedation, IV sedation from our anesthesia colleagues. So we can see the immediate post-ablation changes. Here we can see, again, the contrast study was done. There was no the enhancement of the arterial phase enhancing area seen. And in the post 2 months follow-up, we can see there is the complete response with no residual residual lesion. Now moving on to the few cases of embolization. So this was actually another patient who had underwent post microwave ablation for hepatocellular carcinoma, and he presented after a couple of days. He presented with features of UGI bleed as well as the drop in hemoglobin. So here we can see in the diagnostic angiogram, we can see the branch of the run is taken through the division of the hepatic artery. Here we can see immediate filling of the adjacent portal vein, signifying arterioportal fistula, which was embolized with coil as well as the glue. Another case, here we can see the patient had underwent PCNL for ureteric calculi, nephrolithiasis, and we can see there is hypertensity within this pelvic calcial system, signifying blood products, as well as a large clot within the urinary bladder. So we can see the diagnostic angiogram. We can visualize there is a large pseudoaneurysm arising from the posterior division of the left renal artery, and which was embolized with, again, coil and glue, and showing the complete resolution of the vascular pathology. This was a case, again, this was a female who was a known case of a fibroid presenting with menorrhagia, and she was a Nepali citizen residing in the United States and had come here for the medical management of our symptoms, and we can see a large fibroid as seen in the MRI images, and we took a run through the common iliac artery, and here we can see the vascular nature of the supply of the uterine artery supplying the fibroid. And we super selected the uterine artery, and here this second image showing the injection of the particles. So we embolized this with the PVA particles. Similarly, on the contralateral side, the pre as well as the post embolization run. So we can see there is significant decrease in the vascularity of the fibroid. Another companion case, this was a case of a large uterine artery pseudoaneurysm, but luckily with a very narrow neck, so we were able to trap it with the coils. And this was a special case as this was a gravid female with at around 30 weeks of gestation. So here we can see the fetal skeleton, and the challenge in this case was having to try to minimize the radiation exposure. So another typical case of the bronchial artery embolization, this was a case of fibrobronchiectatic changes of the lingular segment post-TB. So we can see the ectatic vessels, ectatic tortuous vessels, the left bronchial artery, and we embolized it with the PVA particles, 300 to 500 microns, and we can see the immediate changes. So another typical case of conventional TACE for HCC, we can see there is a rapid tumor loss of the hepatoma in this patient, and post-embolization we performed the conventional TACE in this patient with lipidol and doxorubicin as a chemotherapy agent, and we can see a good lipidol deposition within the tumor, as well as the faint, I'll say the very well opacification of the portal vein, which is one of the endpoint for the conventional TACE. So now moving on to some cases of plasty and stentings. So this was a elderly male patient again who had undergone 2 sessions of plain balloon plasty. So this was a refractory patients. He had refractory symptoms. So in the 3rd setting, we underwent the stenting for the central vein, the brachiocephalic vein, and progressively there was decrease in the facial puffiness and the upper limb swelling. Another typical case, a straightforward case here. This is a distal cholangiocarcinoma, and this is you can see this faintly visible the self-expanding metal stent, and where we can see after that placement there is the free passage of contrast into the small bowel loops. Another case of plasty of the inferior vena cava, where we can see there is a complete obstruction with almost no passage of the contrast through the intrahepatic segment of the IVC into the right atrium. So what we did is we navigated through a pterymo guide wire, exchanged it over a stiff guide wire, and then over that guide wire we did the plasty. And then we can see in the post-procedure image there is this relatively free flow of contrast into the right atrium from the IVC. As we have already seen few cases in the talks earlier of the HJ stricture, here the PTBD was done. We can see there is a moderate to gross dilatation of the biliary system with no passage of contrast into the small bowel. So what we did was again navigated it through. We navigated the stricture through the wires, and over that wire we did the angioplasty, and we can see the free flow of contrast. And this patient was managed with serial upsizing of the PTBD drain. And he is still in follow-up with us. So now moving on to a few peripheral vascular cases. So we can see this is the case of the salvage of the thrombosed or the stenosed dialysis fistula, where we can see the run through the arterial limb. There is no free flow of contrast into the venous channel. So we did a plasty with a 640 balloon, and then immediately we can see there is the free flow of contrast through the arterial into the venous channel through the fistula. And this case was of a young female who presented with the lower limb swelling. So she had swelling, the dilated vascular channels at the region of the thigh as well as the leg. And the MRI as well as the ultrasound confirmed the slow flow vascular malformation. And and she is under our treatment currently. So we did the sclerotherapy. We have already done 2 settings with significant improvement in the size of the lesion as well as our symptoms. And we are planning for the 3rd setting in this young female. And on the other case, the final case I have to show now is of the IVC thrombus. So here we can visualize this evident thrombus in the IVC. We can see there is the non-opacification of the common femoral vein. So what we did here was we deployed the IVC filter through the jugular route and took the access through the popliteal vein. And then this is the thrombosuction or the thrombectomy procedures done. We reached up to the IVC femoral vein as well as the popliteal vein, and this was the thrombus aspirated. So post-procedure venogram shows well opacification with the contrast material, and she was continued in blood thinners post-procedure as well. So, so concluding remarks or the reflection, if I have to make on the field of IR, in just 3 points. So I will have to say that IR has come a long way in Nepal, and regarding the potential, there is a very high ceiling to what IR can provide for managing patients and improving the patient's outcome. Having said that, collaboration with other colleagues or the colleagues of other disciplines like the oncosurgeons, oncologists, even the emergency departments, as well as the anesthesiologists. So without their help, we will be lagging at some point. So the main aim would be the collaboration with the colleagues for our improvement as well. And other is that we should be thinking more as a clinician. So we have to retain our clinical knowledge, and also I cannot emphasize more of how good of diagnostic radiology knowledge we require to be a good intervention radiologist. So regarding future prospects, so this is always a lifelong learning. So the intervention radiologists have to train, have to refine their skills, and have to grow with these discussions with other colleagues, or through the short-term trainings, or any modalities or any methods available. And we have to advocate that IR has a far broader horizon than just the FNAC biopsy and pigtail rain, which I believe all intervention radiologists have had a feeling about this at some point of their career. And also, what we have to improve is the exposure to our juniors to the magic of IR in the undergraduate as well as the postgraduate phase. And needless to say, we have still in the number of intervention radiologists in Nepal is still very low. We have probably in the 30s. And so there has been some lag in the research or publications in field of IR. So I encourage all of our colleagues to get involved with some research and publications. So I'd like to thank you all on that note.